So again, same objectives. So definitely know your spectrum of activity. I think when it comes to that, you might be a little bit overwhelmed as far as what covers what. I think one good tip is to kind of know the trends of things and know the exceptions. And so, for instance, know that the drugs that cover Enterobacteriaceae cover E. coli, Klebsiella, etc. So just think of that as a big family of bacteria. Definitely know the drugs that cover Pseudomonas. Know the drugs that cover MRSA, and we'll go through those at the end of these slides. So I think trying to get bogged down into knowing every single drug combo, but rather know kind of the general overall trend. Again, also important to know mechanisms of action and resistance, PK, PD, drug-drug interactions, et cetera, et cetera. So the same objectives as from last week. So again, just to show you where we're at, so we've only made it through these so far, but that's the largest group of drugs, so we've gotten that off the list, and we'll continue through all the rest of these over the next few days. So we left off with the aminoglycosides. Here are the 4 currently available aminoglycosides. Our journey through all different antibodies. So next would be the macrolides and lincosamides. And so we only have one lincosamide, which is clindamycin, so we're related drug to macrolides. And then as you see there, we have our 3 current macrolides, erythromycin, the oldest, which has both parenteral and oral forms, erythromycin, which has only oral forms, and then azithromycin, which has parenteral and oral forms as well. Certainly, these drugs, you don't typically see them used too often when it comes to their parenteral forms, more so these are outpatient drugs used as far as oral regimens primarily. Clindamycin also has a topical formulation that's used for certain specific infections as well. So how do these work? So remember the little clue of Big Mac that I talked to you about in pharmacology, and so macrolides, Big Mac, so as opposed to the 30S ribosome, they inhibit the 50S ribosome. So again, the end result would be inhibition of protein synthesis by the bacterial ribosomes. When it comes to resistance, remember again, so if you know the site of action, you automatically know one mechanism of resistance, right? And so one of those would be the ribosome gets modified structurally, and so the macrolide or lincosamide can't bind, can't inhibit protein synthesis. That leads to high-level resistance, and also it importantly affects macrolides and clindamycin. So if your MIC was 1, for instance, to azithromycin, and that isolate developed this form of resistance, your MIC might jump up to like 16 or 32, so a very high level increase in your MIC. On the other hand, low-level resistance would be efflux, and so there are efflux pumps that span the cell membrane, the cell wall, and they basically, the drug gets into the cell, but then these efflux pumps pump the drug out of the cell into the extracellular environment. So 2 important things about efflux. One is that it causes only a minor level of resistance, and so your MIC might jump, for instance, from 1 to 2, so a pretty minor increase. And often, if you have an isolate that is expressing efflux, you could actually still use a macrolide and probably have a good outcome as far as therapy of that patient. The other important thing about efflux is that clindamycin is not a substrate for efflux pumps, and so clindamycin basically doesn't care about efflux, so it only affects macrolides when it comes to efflux. So like most protein synthesis inhibitors, these are bacteriostatic agents. They also are time-dependent agents as far as their killing. So you see their absorption, so variable PO absorption, fairly low bioavailability, which is not ideal. As far as distribution, as you see there, azithromycin and clindamycin have a fairly good volume distribution, fairly wide distribution. Erythromycin, however, has a fairly low volume distribution. So erythromycin does not get the distribution that azithro and chlorithro are used. So that's the first of many disadvantages of erythromycin. As we'll talk about, erythromycin really is a much inferior drug compared to the other 2 macrolides. Importantly, when it comes to azithromycin gets very high concentrations in your immune cells, so your macrophages and your monocytes. And so if you took a Z-Pak, for instance, and I took a serum blood level from you and looked for azithromycin concentrations in your blood, you would have essentially undetectable concentrations of azithromycin in your blood. If I looked into your monocytes, however, in your macrophages, you would have incredibly high concentrations of azithromycin. And that comes into play for certain infections where you have pathogens that also happen to live in your macrophages and your monocytes. And so there are certain infections where azithromycin is really good because of that intracellular penetration, and there's other infections, which we'll talk about, where it's not so good because you have extremely low levels of extracellular drug. As far as metabolism, so these are really hepatic-eliminated drugs. Clindamycin has some renal elimination. I think an important thing would be the half-life, and so as you see there, another disadvantage of erythromycin, a very, very short half-life, and so we dose erythromycin 4 times a day, for instance, so yet another knock against erythromycin. Chlorithro you see is 5 to 7 hours, and then azithromycin is 6 to 8 hours, and so one of your longer half-lives when it comes to antibiotics, hence the reason that we can use the dosing that we do when it comes to azithromycin. A word about dosing, by the way. So I know some of my colleagues in therapeutics like to hold you responsible for knowing doses on exams. I'm one of those who doesn't really, for the most part, do so. And so you're not going to have to know most standard doses of antibiotics. And so you'll have to know doses, however, when there are very specific rationales for a dose. And so one example would be when we treat otitis media, there's a certain way we dose amoxicillin, taking advantage of its PK/PD properties. And so that would be an example of a dose that I would want you to know. However, for the most part, I don't care if you know what the doxycycline dose is for someone with bronchitis or something like that. So I think it's more important that you know actually how to use the drugs, where to use them, which ones are preferred. Again, not everyone in therapeutics feels that way, but that's kind of my philosophy. Getting into PK of lincosamide, so very high oral absorption, which is an advantage certainly of clindamycin. Very good volume distribution, so wide distribution to a variety of different fluids and tissues as you see there. However, again, like the glycosides, an exception would be poor CNS penetration. And so clindamycin gets extremely low levels in the CNS, and really a drug that you shouldn't see used for meningitis for the most part. Another drug which is metabolized by the liver and renally excreted. So spectrum of activity first of macrolides. And so fairly broad spectrum of coverage, so they cover both gram-positives and gram-negatives. When it comes to gram-positives, they certainly have quite good streptococcal coverage, including coverage of Streptococcus pneumoniae. So we often use these in respiratory tract infections which are caused by Streptococcus pneumoniae. As you see there, in recent years, we've had some emergence of resistance to macrolides in Streptococcus pneumoniae, but it's not really extremely prevalent at this point, and so not a terribly concerning clinical issue yet, but maybe in the future it will be. Fairly good coverage also of MSSA, not so much of MRSA. We'll talk about that in a few minutes here. When it comes to gram-negatives, really fairly minimal activity against gram-negatives, and so definitely no activity against your space organisms, and really pretty limited coverage even against things like E. coli and Klebsiella. And so really, as you see there, from a gram-negative point of view, Haemophilus influenzae and Moraxella catarrhalis, again, two common causes of respiratory tract infections, would be about the extent of the gram-negative coverage of these drugs. Oral anaerobes only, remember again that there's lots and lots of drugs that cover oral anaerobes, and not really a reason that you would particularly use these drugs. These are the first drugs that have activity against the so-called atypical respiratory pathogens, and so you can see there the list of those would be Chlamydia pneumoniae, which is now called Clavidophila pneumoniae, Mycoplasma pneumoniae, and Legionella. And so atypical pathogens are called that for a variety of reasons. One of them is that they grow in, or they require different culture methods to grow them, and so they don't grow in the typical culture media, basically. So atypicals, fairly common cause of things like pneumonia, other upper respiratory tract infections, and so when we talk about things like pneumonia, which we'll do next week, I think, we tend to want drugs that include these atypicals in their spectrum of activity. And so as we'll see, these really are often used for respiratory tract infections, especially azithromycin and clarithromycin. A couple of other kind of niche uses. So these drugs do have activity against H. pylori, and they are used, especially clarithromycin is used in some of the current regimens for H. pylori. And then Mycobacterium avium complex, which is an opportunistic infection, largely a disease of patients with HIV and other really profound immunosuppressive disorders. These drugs happen to be, especially again, clarithromycin and azithromycin are the drugs of choice for Mycobacterium avium complex, which is a huge cause of mortality in HIV-positive patients. So clindamycin, on the other hand, really this is a drug that we use for its gram-positive activity and its anaerobic activity. And so as you see there, from a gram-positive point of view, covers both strep and staph, covers both MSSA and MRSA as long as it's community-associated strains and not so much your hospital-acquired strains. We'll talk about that in a second. Virtually, you can think of it as being absolutely no gram-negative coverage whatsoever. And then oral, fairly good coverage against anaerobes, including some coverage of Bacteroides fragilis, so again, the most important true anaerobe. In recent years, there's been, however, ongoing development of resistance to clindamycin in Bacteroides fragilis, and so clindamycin is more of a second-line drug right now for Bacteroides fragilis. But it is a drug that we use certainly sometimes for its anaerobic coverage. So when do we use this drug? The primary reason right now would be for skin and soft tissue infections caused by CA-MRSA, which is community-associated MRSA. Also used sometimes in anaerobic infections. Used to be used in those below the diaphragm infections, but because of resistance in Bacteroides, not so much anymore. There are also some other niche infections that this is used for that we won't really be talking about, so malaria being one example. We're not going to talk about malaria, but clindamycin has some utility in malaria and some other kind of exotic infections as well. So what is exactly community-associated MRSA and why is this important? So this graph shows the kind of the emergence of MRSA over the years. And so we first saw penicillin resistance in Staph aureus shortly after introducing penicillin. Then we had the development of MRSA shortly after developing methicillin. So as you see there, methicillin was introduced in about 1960 or so. It took only a couple of years to see the emergence of MRSA, so methicillin-resistant Staph aureus. And really for decades, that was really an organism that you would see only in hospitals and other settings like that. So not an organism that you ever saw in the community, basically. And then it wasn't until about 2000, as you see there on the right, that we started seeing infections of MRSA in patients who had no known exposures to hospitalized or hospital settings or other types of institutional settings. And so really, unfortunately, MRSA now is something that you can contract in the outpatient setting if you are unfortunate enough to do so. Another problem with CA-MRSA is that, as we talked about briefly last week, it produces PVL or Panton-Valentine leukocidin, which is a toxin that can cause some really serious damage to tissues, especially when it comes to skin and soft tissue infections. And so community-associated MRSA can cause infections like pneumonia and some other infections, but primarily nowadays is a cause of complicated skin and soft tissue infections, again, in the community setting. So we talk about often where if an organism wants to become resistant, it has to give something up to do so. So we talked a little bit last semester about the idea of fitness. And so if MRSA or if MSSA becomes MRSA, becomes methicillin resistant, it may have to give up a fitness cost. And so maybe it can't grow as well, or it's harder to infect patients, that sort of thing. Community-associated MRSA is sort of the opposite scenario. So in order to develop the ability to produce these terrible toxins that cause so much damage, there was an accompanying cost of resistance. And so if you compare hospital-associated MRSA to community-associated MRSA, community-associated MRSA is treatable by many more agents than is hospital-associated MRSA. So this shows this. So the percent of isolates that are susceptible to different drugs. And so for instance, if you look at ciprofloxacin, sorry, my pointer died. So only about 5% of hospital-associated MRSA strains would be treatable by ciprofloxacin, whereas, as you see, about 3/4 of community-associated isolates would be cipro-susceptible. Bactrim, you see there's not a terrible difference, a little bit less activity against hospital-acquired strains. Vancomycin doesn't really care if you're hospital-acquired or community-acquired, it has activity against both. As you see, doxy, a little bit more equal. Erythromycin really is terrible against both. Linezolid, like Vanco, also daptomycin, like Vanco, doesn't really care all that much. You see Clinda, importantly, has fairly modest activity against hospital-acquired MRSA, but fairly good activity against community-associated MRSA. And so we'll talk a lot about MRSA this semester, but when it comes to especially skin and soft tissue infections caused by community-associated MRSA, you can use things like Clinda, like Bactrim, whereas you would not really use those drugs for patients who have hospital-acquired MRSA infections. Does that make sense? So first going through the adverse effects of macrolides. And so number one on the list would be gastrointestinal. And I think I've said a few times that there really is no antibiotic that doesn't cause nausea, vomiting, diarrhea, etc. But these really cause that. And so especially erythromycin. So yet another knock against erythromycin. You might remember me telling you that in hospitalized patients, especially patients who have been in the ICU for a while, their GI tract sort of starts shutting down, they're not having bowel movements. We use erythromycin intentionally to get those patients' bowels moving again, which I think should kind of give you an indication of the level of GI side effects that, especially erythromycin has. So really terrible nausea, vomiting, and diarrhea. Less of an issue with clarithromycin and azithromycin. And then also from a GI point of view, C. diff infection. So remember again, so C. diff infection is caused by basically disturbing or destroying your normal GI flora. Then if you become exposed to C. diff, you don't have the competition from your GI flora. So really there's not a single antibiotic that is not a potential cause of C. diff, but when we think about drugs that are greater risks for C. diff, macrolides are not at the top, but they're pretty close to the top. So fairly significant cause of C. diff infection as far as the percent risk that you would see with patients. And then from a cardiovascular point of view, so importantly, these are one of the major classes of drugs that cause QTc prolongation. And so they inhibit those HERG channels, those human ether or go-go channels. And so the end result of that is that you have torsade de pointe, which is this fatal, in many cases, ventricular tachyarrhythmia, basically. And so yet another knock against erythromycin. Erythromycin has the worst QTc prolongation, followed by clarithromycin and by azithromycin. So importantly, how do we deal with this clinically? Well, one example would be if someone has a history of ventricular arrhythmias or other arrhythmias, we probably want to be a little bit careful about giving that person a macrolide. And then when we get to drug interactions, we'll see that you want to be careful also about combining these drugs with other drugs that prolong the QT interval. And unfortunately, there's a fair number of drugs that do have that ability to prolong your QTc levels, or your QTc interval, rather. So other adverse effects, some hepatotoxicity, fairly uncommon. This is a class of drugs to which patients are not often allergic, so unlike your beta-lactams, not common causes of drug allergy. Ototoxicity, certainly much less common than is with aminoglycosides, and would really be a side effect that you would see with prolonged high-dose therapy. And then finally, clarithromycin has a noted metallic taste, especially as liquid formulations as well. These side effects certainly much less important for you to remember compared to the previous drugs. So clindamycin, also GI side effects, and so nausea, vomiting, diarrhea. As you see, almost a third of patients can have diarrhea, which is not C. diff-related diarrhea, it's just kind of normal diarrhea. However, this drug can also cause C. diff infection, and so when we think about the drugs that cause C. diff and that pose a risk for C. diff, clindamycin is thought to be the worst offender when it comes to C. diff, and so the drug that you would worry the most about ensuring that patients are not going to get C. diff. Yeah, that said, if you have 10 patients that you give clindamycin to and they all have diarrhea during therapy, probably 9, maybe even 10 of them don't have C. diff, and so certainly just normal diarrhea is more common than is C. diff infection, but again, something to be careful about when it comes to using clindamycin. And then rare liver toxicity, also a rare cause of drug allergy, but you can sometimes see that. So drug interactions. So here we have the first class of drugs that we've talked about that have cytochrome P450 interactions. And so these drugs are strong inhibitors of CYP453A4, which is one of the more important ones that you don't want to have interactions with. And so when it comes to the level of inhibition of CYP3A4, erythromycin, yet another downside to erythromycin, is the worst when it comes to inhibiting CYP3A4. erythromycin, much less inhibition of CYP3A4, and azithromycin is thought to have minimal to no inhibition of CYP3A4, so much less of a potential for drug-drug interactions. So as you see there, the relevance of this is that you have all of these different 3A4 substrates, and if you give these drugs with, for instance, erythromycin, you're going to have inhibition of 3A4 metabolism and elevated levels of these different drugs, many of which happen to be drugs that have major toxicities when you have elevated concentrations. So for instance, you'll have patients who have digoxin toxicity because you gave them the combination of erythromycin and digoxin. Then the other important drug interaction would be additive QTC prolongation, and so as you see there, class 1A, class 3 antiarrhythmics, quinidine, propanamide, amiodarone, sotalol, quinolones, azole antifungals, so fluconazole and those other related drugs, and then methadone as well. So I think one of the cases from last week, there was a patient who was on amiodarone, and you correctly identified that you had to be careful about interactions with amiodarone. These are some really notorious drugs when it comes to drug-drug interactions, and so on exams, certainly be on the lookout for me putting these types of drugs in patient cases, because that should raise a red flag for you when it comes to drug-drug interactions. So a sample question. So which of the following is true concerning resistance to macrolides and lincosamides? More than one answer may be correct. Give you a second to look at those. So does anyone want to vote that A is correct? No. So there's no drug that has not had resistance noted, so that would not be a true statement for any antibiotic, really. What about high-level resistance involves changes to the ribosome? Mm-hmm. Yes? Yes, correct. So that would be high-level resistance, again, a high jump at the MIC, and you wouldn't be able to use a macrolide or a clindamycin for an isolate that had that type of resistance. How about C, true or not? I'm going to say true. Right, so efflux causes that low level of resistance. Again, you could often use a macrolide to treat an isolate that was expressing active efflux. And then clindamycin is affected by efflux only. Seeing some shaking of heads, no. Right, so that describes macrolides, or that rather, clindamycin is affected by ribosomal changes only, and so not efflux. And so clindamycin is not an efflux pump substrate. Some questions on that? Tetracyclines then, so related drugs. So here we have our three currently available tetracyclines. Actually, tetracycline, the sort of parent compound, has recently had some issues with availability, and so from a clinical point of view, you will largely see doxycycline and minocycline used nowadays. All really, although we have parenteral doxy and minocycline, like the macrolides, you'll typically see these agents used as far as their oral regimens. So how do these drugs work? So again, another class of drugs that inhibits protein synthesis that works at the ribosomal level, backs to the 30th ribosome. Mechanisms of resistance. So that first line, penicillins, I don't know how that got in there. So penicillins are not a mechanism of resistance in tetracycline, so just cross that out. I think I was copying and pasting from another slide. So that's not a mechanism of resistance, but you see your two other mechanisms of resistance. So very similar to the macrolides. And so again, efflux, which is going to cause a relatively minor jump in the MIC, and you would still be able to use probably a tetracycline to treat an infection that was caused by an isolate that was expressing efflux. And then like the macrolides, ribosomal changes cause a much higher degree of resistance, and you likely would not be able to successfully treat an infection caused by a bacterium that had ribosomal modification. Like the macrolides, bacteriostatic, also time-dependent killers as well. So very similar to macrolides, other than, of course, the part of the ribosome that they bind to. Absorption, and so minocycline and doxycycline especially have fairly good oral absorption, and so definitely preferred when it comes to tetracyclines, and so 60 to 90% oral absorption. Distribution is fairly good as well, and as you see, some actual appreciable CNS penetration, and so I wouldn't say these are drugs that we use primarily for their role in meningitis, but you could use these drugs sometimes to treat certain cases of meningitis. When it comes to metabolism and excretion, so primarily non-renal, as you see there, again looking at the half-lives, so fairly reasonable half-lives, and fairly similar half-lives between the three drugs, and so these are drugs that we certainly can't dose once daily because of the relatively short half-lives, but they're fairly moderate half-lives that lend themselves to fairly good dosing regimens. Spectrum of activity, so again, fairly similar to the macrolides, and so certainly strep and staph, MSSA and MRSA, really again like the macrolides and like clindamycin, more of a use for community-associated MRSA strains, and you wouldn't typically use these strains, or use these drugs rather, for hospital-acquired MRSA infections. Doxycycline of the three tetracyclines has the best coverage of Streptococcus pneumoniae, which means that doxycycline does have a role in respiratory tract infections, and in fact, for community-acquired pneumonia, there's one subset of patients for whom doxycycline is the preferred regimen to treat those patients. Like the macrolides, fairly modest gram-negative activity. So again, you see Haemophilus influenzae and Moraxella catarrhalis. So again, two fairly easily treatable isolates that happen to cause a variety of respiratory tract infections. Oral anaerobes only. Like the macrolides, these drugs also cover those atypicals, which again lends to their use in things like pneumonia and other respiratory tract infections. A few other kind of niche uses, and so H. pylori do have some role in the treatment of acne, and then Borrelia burgdorferi. Anyone know what that organism causes?
Lyme disease.
Right, so Lyme disease. Actually, there was an article in the paper today about the treatment of chronic Lyme disease, which you might find a little bit interesting, in the controversies about treating patients who have so-called chronic Lyme, which people can't even agree on whether that exists or not, and so using long-term antibiotics. And so there was an article just in the Press Herald today about that. So adverse effects, gastrointestinal. So really, these are drugs that aren't very high in the list when it comes to causing C. diff. They certainly can. Again, all antibiotics can cause C. diff. Even the antibiotics that we use to treat C. diff can cause C. diff. But these are fairly low-level risk when it comes to causing C. diff. However, like every other drug, basically, it can cause some GI side effects like nausea and diarrhea, especially if you don't take these with food. Neurologic side effects are primarily associated with minocycline and really are more with long-term high-dose therapy, so nothing that you would ever really see in sort of a week's course of therapy. Again, like the last few drugs we talked about, fairly uncommon causes of drug allergy. These agents, though, can cause candidiasis, so oral thrush and vaginitis. And so, as you'll learn later in the semester, candidiasis really is an infection that, again, like C. diff, arises from destroying the normal flora. And so, these agents, unfortunately, can lead to secondary fungal infections because of the disruption of your normal flora. Photosensitivity, so this is the first class of drugs where we've really seen photosensitivity as a side effect, and so these are certainly drugs where you want to tell patients, don't take your tetracycline and then go out laying on the beach for a week down in Mexico or something like that, because they can cause extremely bad burns when it comes to their ability to cause photosensitivity. Hepatotoxicity, so like many of you, my parents have a medicine cabinet at home that has all kinds of expired medications, and is there a risk in taking those medications? Probably not. This would be one exception, however. So expired tetracyclines, you really don't want to take those because they can cause hepatotoxicity, often fatal hepatotoxicity, especially. And then tooth discoloration, and so we want to avoid these agents in children less than 8 because it'll cause tooth discoloration while they're still developing their teeth. That also leads to the fact that these are contraindicated in the 2nd and 3rd trimesters of pregnancy because you can have that same effect in the fetus. And so these agents are pregnancy category D, which is one of the lower risk categories that you'll see when it comes to antibiotics. And so most antibiotics are going to tend to be usually pregnancy category C is fairly common for antibiotics, but these are a D, so definitely a more contraindicated class of drugs when it comes to pregnant patients. So drug-drug interactions, again, sorry, penicillin's kind of crept in there, I don't know why. exactly. These don't interact with penicillin, so just cross that off, sorry. However, there is chelation with divalent and trivalent cations, and so what this means is if you don't space these drugs from things like aluminum, magnesium, zinc, iron, calcium, then you'll have chelation, and essentially you'll be giving the person placebo doxycycline, basically. So things like antacids, mineral feeds, calcium supplements, and so really the only thing to do with this is this wouldn't be a reason to avoid giving one of these agents, but you have to just make sure that you tell patients to space these drugs by a couple of hours from their antacid or their Tums, etc. When it comes to decreased concentrations, you can have some interactions with anticonvulsants, things like phenobarb, phenytoin, and carbamazepine, also with rifamycins. I wouldn't consider these to be extremely important drug interactions, nowhere near on the level of severity of what we saw with the macrolides, certainly. And then finally, there's a really kind of cool, I think, interaction with digoxin, which is caused not by a cytochrome effect, but there is a GI bacterium that is responsible for metabolizing digoxin. Tetracyclines can kill off that organism, and so you lack the ability to have metabolism of digoxin, and so you can have digoxin toxicity because you have reduced metabolism. And so, interestingly, caused by killing of the bacterium that is responsible for helping to metabolize digoxin. So another sample question. So which of the following is covered by doxycycline? More than one answer might be correct. Pseudomonas, anyone? So no coverage against Pseudomonas. Atypical pathogens? Yep, so atypical, so again, chlamydia or chlamydophila pneumoniae, mycoplasma pneumoniae, Legionella would have activity against all three of those. MSSA? Yep, good staph coverage. Streptococcus pneumoniae? Yes, so also good coverage of streptococcus pneumoniae. And again, a reason that we could use doxycycline in respiratory tract infections. Am I going too quickly? Is this okay? I know it's sort of overwhelming and it's like drug after drug after drug, but again, I think it's important that you have sort of this baseline knowledge, which should help you as we start talking about diseases, and you'll kind of know how these drugs work and et cetera. So next would be a fairly quick group of drugs, so our folate antagonists, and so you have your sulfonamides, sulfamethoxazole, trimethoprim, TMP-SMX, and sulfadiazine. Definitely we'll be focusing our attention on TMP-SMX, which is by far the most common example of this that you'll see clinically speaking. So how do these drugs work? They inhibit folic acid synthesis, and so bacteria have to make their own folic acid, which then gets involved with a pathway that helps in the synthesis of DNA. And so you have these two sequential enzymes in that process of synthesis of folic acid. So you have dihydrotaurate synthase, or DHPS, and then you have dihydrofolate reductase, or DHFR. So those are enzymes involved in sequential parts of that pathway, where bacteria make their own folic acid. And so these two drugs, so the sulfonamides inhibit DHPS enzymes, and trimethoprim inhibits DHFR enzymes. And so if you use one of these by themselves, they would only be static, but when you combine them, you have basically synergistic activity, and so you have then societal activity. So a reason that we typically use these drugs in combination, and you'll rarely see TMP or SMX used by itself. When it comes to resistance, alterations again in the target site are the most important means of resistance. And so again, you have an altered, for instance, DHFR enzyme that trimethoprim can't bind to any longer, and so it can't inhibit that step in the folic acid pathway. These drugs are thought to be concentration-dependent killers. We don't really know a lot about the pharmacodynamics and the killing activity of TMP-SMX, despite the fact that they are extremely old drugs. Absorption, so very good absorption. So again, we're talking primarily about TMP and SMX, so over 90% oral absorption, which is good. Extensive distribution. I will highlight the fact that these get excellent penetration into the urine, and so you get extremely high concentrations of TMP and SMX in the urine. Hence, one of the main clinical uses of TMP-SMX would be in the setting of UTIs, especially uncomplicated urinary tract infections, which are a fairly common infection. When it comes to metabolism and excretion, it's sort of a mixture of hepatic plus renal excretion and metabolism. As you see there, the half-lives of TMP and SMX are fairly similar, so 11 hours for TMP and 9 hours for SMX. So it leads itself to twice daily dosing, so a fairly convenient way of dosing these drugs based on those pretty moderate half-lives. So spectrum of activity, so gram-positives. Okay strep coverage, not really great strep coverage, and you wouldn't typically use TMP SMX if you were really suspecting that strep was a fairly likely pathogen that was causing an infection. Staph, on the other hand, pretty good staph coverage of MSSA and MRSA, although again with the caveat that we typically would use these primarily for community-associated MRSA infections and not so much for hospital-acquired infections. From a gram-negative point of view, these would cover most of your Enterobacteriaceae, including E. coli. So combined with the fact that these get extremely good urine concentrations and the fact that E. coli is the most important cause of UTIs, another reason why we use these drugs commonly to treat UTIs. Centrophimonas multifilia is a kind of rare, but unfortunately multi-drug resistant gram-negative that typically causes infections in hospitalized patients. TMP SMX happens to be the drug of choice to treat those infections. Anaerobes, really no activity. And then again, you have some other kind of niche organisms, things like Listeria. Nocardia is an infection that typically occurs in patients with really bad immunosuppressive states, so patients with HIV, etc. And then Pneumocystis urevetsii, which used to be called Pneumocystis carinii. Has anyone ever heard of that organism? So that's so PCP infection is. So PCP was the organism that was found in the first cohort of patients that were later found to have HIV infection. It wasn't known at the time they had HIV, but really this is PCP infection is kind of the way that HIV was discovered, if you will, because there were a small cohort of patients who presented with PCP infection. And so as you'll learn later on in the semester, TMP SMX is the drug of choice for PCP infection. Adverse effects, again, some GI side effects, but again, what doesn't cause GI side effects? But as you see, fairly frequent, so almost a half of patients can have some degree of nausea and vomiting, especially with higher doses. Bone marrow suppression, so you can have folate deficiency and related bone marrow suppression. Again, more common with high-dose therapy and with long-term therapy. So if you have a patient who has, let's say, acute uncomplicated cystitis, the course of Bactrim for that infection would be how many days? Anyone know? 3 days, yes. Or 5 and 7. So 3 really is the commonly accepted regimen. So if you gave a patient 3 days of TMP SMX, are they going to have bone marrow suppression and thrombocytopenia? Probably not. So it's more with long-term therapy. So for instance, patients who have PCP infection, they might be on lifelong Bactrim, and then it becomes a more important concern. Also from a renal adverse effect point of view, these can cause what are called false elevations in creatinine through another mechanism of action. So you have a patient who's on Bactrim, again, especially long-term, high-dose therapy, their creatinine bumps, and you might think that you've had a patient who has renal dysfunction, but really it's this idiosyncratic false elevation in creatinine, which does not indicate actual true damage to the kidneys. Other adverse effects, so as I said, penicillins and other beta-lactams are the #1 cause of antibiotic-associated allergy. This is #2 on the list, and so a fairly common cause of drug allergy, unfortunately. So rash, pruritus can also cause things like Stevens-Johnson syndrome. We learned about Stevens-Johnson yet, so I would put a picture up, but I find pictures of Stevens-Johnson and related disorders extremely disturbing personally. So again, that really severe skin sloughing and things like that, which creep me out, frankly speaking. So, so if you have a patient who ever had Bactrim-induced Stevens-Johnson syndrome, for instance, that would be a reason to never give that person Bactrim ever again, basically. And usually it's the sulfonamide portion of Bactrim that is responsible for drug allergies, not so much the trimethoprim part of the compound. And then from a pregnancy point of view, so these are agents that are, while they're pregnancy category C, you should avoid them during the first trimester and also at the near-term point of view as well. So other than that, thought to be fairly safe for pregnancy, but pregnancy category C, again, avoid their use during the first trimester and near-term. Can cause neural tube defects and also hyperbilirubinemia and jaundice in the fetus. Drug-drug interactions. So there are many antibiotics that are thought to interfere with the activity of oral contraceptives, and these are one of the most notorious ones. So from a clinical point of view, you want to just make sure that you counsel patients while they're receiving their Bactrim, and then for a period of time after that to be careful and to either abstain from sexual intercourse or use alternative methods. When you combine these drugs with ACE inhibitors, you can have additive hyperkalemia. And then from a bone marrow suppression point of view, if you use these drugs with methotrexate, you can have some additive bone marrow suppression. Again, not something that is a concern with a short 3-day course of Bactrim, but again, more with long-term, prolonged courses with high doses of therapy especially. So any questions on folate antagonists? All right, so quinolones next. So here are the 4 available fluoroquinolones, and so ciprofloxacin, levofloxacin, moxifloxacin, and gemifloxacin. I know that there are some topical formulations of some other quinolones, and so for instance, gadafloxacin, there is, I think, either an ophthalmic or an otic formulation of gadafloxacin. I pretty much ignore those formulations when we're talking about therapeutics, and so we're going to really limit ourselves to the systemic fluoroquinolones. So all 3 of the 4 of these have both parenteral and oral formulations. Gemifloxacin is the only one that has only an oral formulation. So mechanism of action, these inhibit topoisomerase enzymes, and so topoisomerase 4 and DNA gyrase are topoisomerase enzymes that are involved with DNA synthesis, so involved with things like the supercoiling and relieving of the supercoiling of the DNA strands during that synthesis and replication process. So in the end result, bacteria can't synthesize DNA and so can't survive. When it comes to resistance, sort of similar to the tetracyclines and the macrolides, where you can have active efflux, and so efflux pumps again that pump the drugs out of the bacterial cell where they can't work any longer. Like the macrolides and like the tetracyclines, this is a low level of resistance that causes only a minor bump in your MIC. And again, you could likely cause, or rather use a quinolone for an infection caused by an isolate that was expressing efflux, and you probably would have a perfectly reasonable clinical outcome in that person. On the other hand, you can have, again, target site modification, so you have a modification of either topoisomerase 4 or DNA gyrase, and the quinolone is trying to bind to the enzyme and basically can't bind, and so can't inhibit the enzyme, so you have basically uninterrupted DNA synthesis. Like the macrolides, the tetracyclines, and clindamycin, that leads to a much more profound level of resistance, a higher elevation in your MIC, and if you use a quinolone in that scenario, you likely would have treatment failure because of that higher level of resistance. These are cidal agents, unlike some of those we've talked about recently, and they also are concentration-dependent killers. Pharmacokinetics all have fairly good bioavailability, some higher than others. Food does delay absorption and time to peak concentration. From a distribution point of view, fairly good distribution, including the CNS. These wouldn't be at the top of the list as far as drugs that get good CNS levels, but they're fairly good, and we do sometimes use these agents for the treatment of meningitis. From a PK point of view, I think one thing to point out certainly is that moxifloxacin is the only quinolone that doesn't get appreciable levels in the urine. And so when it comes to UTIs, which again quinolones like Bactrim are often used for, moxifloxacin would be the exception to that rule, and you shouldn't be seeing moxifloxacin used for urinary tract infections because of low urine concentrations. When it comes to metabolism and excretion, both renal and hepatic, again, moxifloxacin, however, has minimal renal elimination, hence you shouldn't see moxi for UTIs. Spectrum of activity is quite broad, actually, and so these have activity against, from a gram-positive point of view, strep, MSSA, not very good coverage of MRSA, and if you would use these agents for MRSA, it again would be more of those community-associated strains. And early on, after the development or the emergence of those community-associated strains, quinolones became one of the drugs of choice for those isolates. But what you see when you use a quinolone for a community-associated, say, skin infection is that you have fairly rapid development of resistance to the quinolone that happens during therapy. And so these have kind of fallen out of favor as agents, even for community-associated MRSA. So when it comes to their gram-positive activity, ciprofloxacin is definitely the poorest, and of the quinolones, cipro is the only one that really you can't rely on its strep pneumonia coverage or other strep coverage. Levo, Moxie, and Gemi, on the other hand, are so-called respiratory fluoroquinolones, and so they have good coverage of Streptococcus pneumoniae, and so we use these agents in things like pneumonia, other upper respiratory tract infections, things like sinusitis, etc. When it comes to gram-negatives, these really all cover the Enterobacteriaceae, so they're all going to have activity against E. coli, Klebsiella, etc. They also cover H. flu and Varicella, so again, respiratory pathogens that are treatable by many different drugs. There are some Neisseria species that are treatable by quinolones, and so when it comes to the Neisseria species, the two most important would be Neisseria gonorrhoeae and Neisseria meningitis. Quinolones were once the drugs of choice for gonorrheal infections. However, because of resistance, they are completely not recommended anymore, unfortunately. However, for Neisseria meningitidis, so a fairly common cause of meningitis, the quinolones do have a role in the treatment of meningitis caused by Neisseria meningitidis. Another big question becomes, can you use these drugs to treat Pseudomonas? And so as you see there, you can, but only Levo and Cipro have reliable coverage against Pseudomonas, and neither Moxie nor Gemi should be used for someone who has a suspected or a documented infection with Pseudomonas. When it comes to anaerobes, these do have some activity even of your below the diaphragm anaerobes, your things like Bacteroides fragilis. However, the only one that really is reliable would be moxifloxacin, and so we sometimes do use moxifloxacin for intra-abdominal infections and other infections where you're worried about those true anaerobes. Also, like the tetracyclines, the macrolides, these drugs do also cover those atypical pathogens, so your atypical respiratory pathogens. So given the coverage of Streptococcus pneumoniae, the coverage against atypicals, a common place you'll see these would be in the management of things like pneumonia and other respiratory infections. Just showing more of the kind of the spectrum of activity, I guess. So nalidixic acid was actually the first quinolone ever developed. It's not available as a commercially available therapeutic agent any longer. So again, just remember that Cipro really is much more of a gram-negative agent, lacks coverage of Streptococcus pneumoniae. Gemi and Moxie are better gram-positive agents. And I really think of Levo as kind of being in the middle here and sort of having a little bit of a mixture of gram-positive and gram-negative activity. I think Levo is probably not your best gram-positive agent nor your best gram-negative agent. I think Levo really is sort of, in my opinion, kind of a mediocre, overused drug that doesn't really cover anything the best, but covers lots of things reasonably well. So I have a bit of a pet peeve, I guess, if you will, when it comes to levofloxacin use. I think partly because Levo, as you may have seen in the community, is very commonly used. Nowhere near as often maybe as Z-Pak, but it's up there certainly in the incidence of drugs as far as being prescribed. So that's my Levo rant, I guess. So adverse effects, GI, so again, nausea, diarrhea. These are not the most important cause of C. diff. They're up there though, and they're probably number 2 compared to clindamycin. However, even more importantly, as you'll learn later, we in recent years have had these what are called hypervirulent strains of C. diff that cause extremely severe infection, also are more difficult to treat, and quinolones are a great risk factor for acquisition of those hypervirulent strains of C. diff. Another class of drugs that can cause photosensitivity, so you want to caution patients, again, not to go out on the beach after they've taken their course of Cipro or during their course of Cipro. Neurologic side effects would be more with long-term therapy and chronic therapies of headaches, dizziness, agitation, insomnia. Aggravated often if you have concomitant long-term high-dose NSAID use. And then, again, from an allergy point of view, not a very common cause of allergy, but can sometimes cause allergic reactions. adverse effects. So like the macrolides, here we have another class of drugs that is fairly notorious for causing QTc prolongation. So again, a risk factor for that ventricular arrhythmia of torsade de plante. When it comes to the quinolones, they really can all cause this, but levo and moxie are thought to be the most risky when it comes to causing QTc prolongation. Tendinopathy, another fairly famous side effect, and so you can have patients who have spontaneous ruptures of their Achilles tendons, for instance, and so definite risk factors for that would be age greater than 60, also receiving corticosteroid therapy, and also really engaging in exercises that are going to stress that part of the body. And so, for instance, if you have someone who's a marathon runner, you probably should advise them to hold off on the running while they're taking their quinolone, basically, because that type of patient would be at risk for having that spontaneous Achilles rupture. Then related would be cartilage injury, and so no quinolones are approved in children under the age of 16 because there's thought to be a risk for impairing the development of bone and cartilage during that time frame. And so you won't often see these drugs used in pediatric patients. That said, most of the evidence to support quinolones causing cartilage injury is in animals and not humans, but in dogs, for instance. And so there actually have been studies in poor beagle dogs and showing that quinolones can inhibit cartilage development in beagles. There's very little in the way of human data when it comes to that cartilage toxicity. And so especially, let's say, in children's hospitals where you have really seriously ill children with infections caused by things like Pseudomonas, et cetera, you will see quinolones used in children, but they're not approved for the use in children, so it's definitely an off-label use. And then finally, dysglycemias, and so especially moxifloxacin, and so gadafloxacin, which, as I mentioned, has, I think it's eye and or ear formulations available. Can anyone confirm that?
Definitely eye.
Definitely eye, okay. Maybe not ear?
Yeah.
So gadafloxacin used to be also available systemically. However, it was noted that patients were having a lot of episodes of either hypo or hyperglycemia, including some fatalities. And so in the end, gadafloxacin as a systemic agent was pulled from the market because of those toxicities. The remaining quinolones do have that side effect as well, especially moxifloxacin. So you just want to be careful, especially in patients who have pre-existing diabetes, that you're careful about using quinolones because you might cause hypo and or hyperglycemia. Drug interactions, so another class of drugs where you have this chelation. So again, not a reason why you should tell someone to not take a quinolone, but this would be a reason to basically advise the patient to space their quinolone with their antacids, their calcium, their Tums, their milk, etc. So definitely just a counseling point, but again, not a reason why you would avoid the use of these drugs. Like the macrolides, added QTc prolongation, and so again, things like azole antifungals, macrolides, methadone, etc. So you want to be careful and not use these drugs in combination with those agents. And then from a CYP point of view, these drugs thankfully have little in the way of CYP interactions, with the exception of Cipro, which does have some inhibition of 1A2. And the most important clinically relevant interaction here would be warfarin. So you can have elevated warfarin concentrations in patients who are on Cipro at the same time. So it's another sample question. Which of the following has the poorest activity against Streptococcus pneumoniae? What do you think? D? C? B? A? Yes, A. So again, Cipro is the only quinolone that really has, in your head, think about it as really no activity against Streptococcus pneumoniae. It's not true that it has really literally no activity, but I think it'd be easiest if you thought about it in that way. And so if I wanted to give a patient who had community-acquired pneumonia ciprofloxacin, I would not be providing that patient adequate therapy in most cases, because Streptococcus pneumoniae is pretty much always going to be a concern in patients with community-acquired pneumonia. So, want to do one more, or what do you think?
Just one.
Let's call it
Just one?
Just one.
You're gonna see me for the next few hours anyway, so.
We can count this one as one more.
One more?
This
Alright,
is one more.
do one more.
Let's count this one.
So gram-positive agents. And so, which is really not an official term for these drugs, but they're really newer agents that are used pretty much for their gram-positive activity, and that's the only reason that you would, or one of the only reasons you would ever see these drugs used. So vancomycin is definitely our, our kind of key example of an agent like this. And so vancomycin available both in IV and oral formulations. We'll talk primarily about vancomycin. However, we do have these other three. So vancomycin is a glycopeptide. The other three are lipoglycopeptides. So derivatives of vancomycin. And so telavancin was approved in 2009. And then interestingly, as you see there, dalbavancin and oritavancin were approved in 2014. So as I mentioned a couple of times, we seem to be in this really weird but exciting time where we're suddenly actually having new antibiotics come out, which is, again, a new thing for us in antibiotics. So we'll talk primarily about vancomycin, although a lot of the same things will hold true for the other drugs. And so another agent that inhibits cell wall synthesis, however, it happens at a different location, so it doesn't inhibit, for instance, penicillin binding proteins, but it binds to another precursor that is involved with synthesis of the cell wall. So as you see there, you have these tripeptides that have a D-ala terminus, and vancomycin binds to that D-ala terminus, and cell wall synthesis is inhibited. So similar to your beta-lactams, but a slightly different target where that happens. From a mechanism of resistance point of view, so when I was in school, vancomycin-resistant enterococci were all the rage, and so that was one of the more notorious resistant pathogens. And so I graduated in 1998, showing my age, I guess. So at that time, VRE, vancomycin-resistant enterococcus, was the huge concern, and everyone was worried, what if enterococci could ever give its resistance to staph? And at the time, especially when it comes to MRSA, we had very few drugs that could treat MRSA. And so that was always sort of the doomsday scenario of what if we ever had vancomycin-resistant staph. So then when we first saw resistance to vancomycin, which was intermediate resistance, so a relatively minor elevation in the MIC, actually it was a thickened cell wall that caused that resistance. We'll see that in a second. And then it wasn't until later that we truly saw fully vancomycin-resistant staph aureus. When it comes to their cidal activity, so vancomycin is cidal, but when you compare it especially to beta-lactams, it's both more weakly cidal and it's more slowly cidal. And so vancomycin offers a lot of advantages, primarily when it comes to its spectrum of activity, but from a killing point of view, it's a fairly inefficient drug. And so there are some clinical scenarios where a beta-lactam becomes the much preferred drug compared to vancomycin, again, because of that better killing and more efficient killing. And then these are thought to be, as well, time-dependent killers. So I think I won't go through all of the gram-positive. Maybe I shouldn't have jumped into these, but we'll talk about resistance to vancomycin, and then we'll continue with these drugs tomorrow. So unless anyone's dying for me to finish them, probably not. So we'll talk just about resistance to vancomycin, and then we'll continue tomorrow. So again, as I mentioned, back in the 90s, VRE was all the rage. It was one of the more important resistant pathogens, and the cause of vancomycin resistance in enterococci was a change in the binding site. So again, vancomycin can only bind when it sees that D-ala appendage at the end of the peptidoglycan. So enterococci basically changed that D-ala to a D-ala D-lac. Vancomycin then could not bind, basically. So that was what led to vanco resistance in enterococci. Again, everyone was really concerned about that being spread to staph. And then, as you see here, these photos are from a 1999 article, which was the first report of so-called Visa or Giza strains. And so vancomycin intermediately susceptible to staph aureus. And so what happened actually was that these isolates developed this resistance independently from enterococci. So this didn't come from enterococci, it just happened intrinsically. And so the mechanism of resistance here is a thickened cell wall. So on the top here, you have a vanco-susceptible cell wall, and then you have a much thicker cell wall. As you see, the top image is a vanco-susceptible Staph aureus. The bottom image is a Giza or Giza strain. So really, these developed these really thick cell walls. And so if you think about it, vancomycin is trying to get through that cell wall to act, and it just basically reaches the point where it can't get through there anymore. So that was the mechanism of resistance, or intermediate resistance. And these organisms, by the way, you can often still use vancomycin to treat them. You may have to use higher doses and be a little bit more cognizant in your concentrations, but you can still sometimes have clinical success when you treat these isolates. So then finally, so what we always feared happened finally in 2002. And so this is where enterococci, staphylococci, they got together, they swapped DNA basically, and so this VAN-A gene, which was responsible for this change from D-ALA to D-ALA-D-LAC, was transferred to Staph aureus. So in the end result, Staph aureus acquired the ability to have that same mechanism of resistance to that change again in the target site. So as opposed to VISA or Visa or Giza, where you have a relatively moderate elevation in the MIC and you can maybe still get away with using vancomycin, these isolates all are very highly resistant to vancomycin, very high MICs, and patients who have VRSA strains often had failure of therapy of vancomycin during the course of therapy. So really this was that kind of doomsday scenario that everyone was always worried about, because again, we didn't have very many drugs to treat MRSA, and so the thought was that if we ever had vancomycin resistance to MRSA, it'd be the end of the world, basically. And so the only kind of, I guess, positive about VRSA is that we've had very few cases of it happening. And so, as you see, it was first reported in 2002, and yet worldwide, we've had, I think it's still less than 30 cases reported in that time. And so no one really knows the reason for that, but thankfully this has become not very prevalent. If it ever does, then that might be the end of the world, who knows. But for now, a fairly uncommon infection, thankfully. So I think I will stop there. I guess I'll see you in 20 minutes or so. Any questions?